Well, it's 6:33. I'm guessing we should get started. I'm hoping everybody can hear me. I'd like to start by introducing myself. My name is Daniel Southern. And what you need to know about me is I'm the only Regenetics affiliate in the state of Connecticut. I'm one of the few on the East Coast. I'm one of the very few that does spinal procedures as well. I want to thank you all very, very much for joining tonight, taking time out of your busy schedules. We're having a nor'easter here on the East Coast. I'm sure those of you who are local are experiencing the same thing, and I appreciate you spending some time with me tonight. I want to talk about knee pain, a regenerative orthopedic approach, a non-surgical advance in the treatment of joint pain. I want to jump right in with how a knee becomes painful, and then we'll talk about how we treat that in regenerative medicine. So how does a knee become painful? When we get older, cartilage thins out, it craters, ligaments loosen, the knee begins to slip with movement. Now, this can be imperceptible, but the tip-off that it's happening is the clicking, snapping, and popping that you hear in your knee. And what this slipping does is it causes instability. An unstable joint is a joint that is unhealthy. It is a joint that is going down. Instability accelerates degeneration in the joint without a doubt. Another thing that accelerates degeneration in a joint is injury. An injury can also lead to instability. And one note here is that surgery is a form of controlled injury to any joint. So any joint that's had surgery is a joint that can be at risk of accelerated degeneration. Here's a schematic of the healthy balancing act that occurs inside any joint. There's a balance between forces that degrade the joint and forces that repair the joint. So let's say you're getting older and you've got a history back in high school, college, where you sprained your knee badly, maybe on the athletic field, it swelled up, you hobbled for a bit, it got better on its own, it didn't require treatment, you forgot about it. But now that knee is starting to bother you again. Let's say you put on a few pounds, you're carrying a little more weight than you normally should. So what that's doing is it's loading this joint unnaturally. It's carrying more load than it should. If you're smoking, you're killing cells in your cartilage that keep a joint healthy, period, end of story. You're eating poorly, you're not eating as well as you should, you're eating a pro-inflammatory diet, chronic inflammation destroys a joint. Your fitness level is not the best, it could be better. Therefore, the knee is not as stable as it might be. You're leading a sedentary lifestyle, which contributes to the same. In essence, what you've basically done is you've increased the forces that are degrading this joint, and you're tipping this seesaw in the direction of degradation. Proper joint alignment is very, very important, and it's something that we pay a lot of attention to in the Regenetics world. There's two forces that stabilize a knee and provide for good alignment, and those are your muscles, which are the dynamic stabilizers of any joint, and the ligaments, which are the tough bits of connective tissue which hold the bones together. These are called the static stabilizers of any joint. They ensure proper alignment in a joint, and a proper alignment balances the stresses that are applied to a joint during motion. And these forces should be equally distributed in all directions so that one part of the joint is not being unnecessarily stressed. Proper alignment allows for the greatest support with the least amount of stress and the greatest range of motion with the least amount of effort. Here's a schematic showing what happens with poor alignment. Poor alignment leads to instability, and instability, as we just mentioned, contributes to degeneration in any joint. Let's say you've got a pelvic tilt here. Your pelvis is kind of off axis, and this could be for a number of reasons, including a pinched nerve in your back, including the way you were born. You could have a leg length discrepancy here causing this. What a pelvic tilt will cause is the knee to roll in and the ankle to roll in. So that causes, ankle and knee pain. Because your pelvis is tilted, you have back pain. You're compensating with your shoulders and your neck, so you have neck pain. The neck pain leads to headache. This illustrates the interconnectedness of all your joints via the kinetic chain. The kinetic chain is a fancy way of saying the ankle bone is connected to the knee bone, is connected to the hip bone. Alignment in one joint affects the alignment of another joint. So if you've got poor alignment in one joint, the adjacent joint could be at risk for degeneration and pain. Poor alignment in any joint decreases the support that's inherent in that joint. It increases the effort required to support yourself through that joint. It decreases the range of motion of the joint, and it increases stresses in the joint. Here is an illustration of poor alignment in the entire body. In addition to looking very poorly, it results in injury. So let's say you've injured your knee. The standard treatment algorithm today in orthopedics is a knee injury leads to, some acute triage. You take some ibuprofen, you put some ice on it, it swells up, it's painful, you hobble for a few days, and it gets better or not. If it doesn't get better, you call the primary care doc. He says, gee, it doesn't sound terribly serious. Why don't we go to physical therapy? So you do a little bit of rehabilitation on it. And that usually solves the problem. But when it doesn't, and you go back to the primary care physician, he usually sends you to his friend, the orthopedic surgeon, who takes a look at you and says, hey, you're not getting better. You've had physical therapy. Let's do a steroid injection. And that may or may not work. Sometimes it works fantastic. Other times it doesn't. He may suggest a gel shot, which is hyaluronic acid. But assuming the injection therapy doesn't work, he's going to order an MRI. Now, if you're standing in a surgeon's office and an MRI is ordered, your chances of getting surgery go up 90%. So let's say you have that surgery and it's successful, and you go about your business. And maybe years later, it starts bothering you again, or it didn't work. And what happens? You go back and you have another surgery. And years go by, and the problem was never really solved, and you still have pain. And now you're a candidate for total joint replacement. So this represents the algorithm, the standard treatment algorithm in any orthopedics office in this country today. What's wrong with that? Well, there's a few things that's wrong with that. Steroid injections, number one. Steroids are toxic to tissues, and they kill the very cells that we want to support to keep your knee joint healthy. They kill chondrocytes that are alive in cartilage. They kill fibrocytes that are alive in tendons. They kill synoviocytes alive in the joint capsule. Steroids reduce the joint cartilage volume. Steroids weaken ligaments. It weakens bones. They suppress the immune system. They increase your risk of diabetes and your risk of infection. They're really not good. And in the laboratory, if you add steroids to anything that you're growing in culture, it will die immediately. The local anesthetics, the canes that we usually inject with steroids in a joint, bupivacaine, lidocaine, these are probably even more toxic than steroids. Lidocaine will kill 90% of chondrocytes, which are the cells that live in cartilage, at 1 hour of exposure. What's wrong with the current algorithm? Surgery. We refer here to meniscectomy, which is quite often the let's clean up that arthritis surgery. It's taking out a big hunk of cartilage called the meniscus in your knees, which provide tremendous cushioning force. And that's usually done because they've spotted a tear on MRI. Well, make no mistake, when you have this type of surgery done, your risk of arthritis increases, and it increases threefold over the course of the next 8 years. And why is that? Well, it's not rocket science. If you take out the hunk of cartilage that provides cushioning forces in the knee, what you've done is you've increased the loading forces in the knee, and increased loading forces contribute to more rapid degeneration in the knee joint. What's wrong with the current joint treatment algorithm? Joint replacement. It's really amazing, but studies show that following joint replacement, only 1 out of 20 patients who have joint replacement, that's 5%, achieve normal activity levels. This is a study by Harding in 2014. Many patients are really no more active after joint replacement surgery, when that's really the promise of it. Many patients continue to complain of pain, and this is up to 50% of patients. They have pain 3 to 5 years following total joint replacement. And then, of course, there's the risk of metal and material fragmentation from the prosthesis that they put in after they take your native joint out. And this is a common and scary problem. So what's the promise of regenerative orthopedics? Well, regenerative orthopedics promises not to do surgery. It is the use of the body's ability to heal itself. What we're doing with regenerative orthopedics is that we're harvesting repair hormones and cells from our patients. We find them in the blood, we find them in the bone marrow. And in the bone marrow, we find something called MSCs. These are called mesenchymal stem cells or adult stem cells. And these repair cells are called orthobiologics. We're using a patient's biologic tissues to treat orthopedic conditions. So we conflate those two terms and we get the term orthobiologics. We take these cells, we concentrate them, we focus them at sites of injury, and this is key. The reason why we have to do this is because the sites of injury in orthopedics, cartilage, ligaments, tendons, and bone, all of these tissues have a very poor blood supply. So they do not have access, sometimes adequate access, to these repair cells and hormones. So what we're doing is we're bringing those repair cells and hormones to the joint that needs it. Regenerative orthopedics is minimally invasive. All we're using is needles. This reduces or eliminates operative trauma. There's minimal recovery, and there's much less painful rehab. And the bottom line is that rather than amputate your native joint with a total joint replacement, hopefully we're able to preserve your native joint. And that's huge. So this brings us to regenerative orthopedic joint treatment. What is it? Well, as we just mentioned, it's not surgery. It's not just a simple injection into a joint either. It is a comprehensive treatment aimed at understanding and correcting the dysfunction that's causing you pain in that joint. There's basically 4 steps to a regenerative orthopedic joint treatment. We're going to trot through them very quickly here. Step 1 is we need to get a better diagnosis. Why this joint? Here's a picture of a very degenerated hip joint. This joint here, you can see no joint line whatsoever. It's really, this is your bone on bone look. Over here, you can see a space between the ball joint and the cup joint side of the joint in the hip. Here you can't. So the question is, why this joint? And why not this joint as well? Why just this joint? Well, that's a clinical investigation. And we find out a lot as doctors when we do a physical exam. And what we're looking for is weakness of muscles around this joint, laxity in the ligaments of this joint, limitations in its range of motion. All of these things can lead to poor alignment and instability and increased joint loading forces, which could help to explain why this joint now looks like this and is causing you terrible pain. The history gives us a big clue. Quite often, joints that look like this are joints that have had some type of trauma in the past, and that could be surgery, could be a prior surgery 20 years before. There could possibly be a failure or limitation of an adjacent joint. A hip that looks like this could have chronic locked up sacroiliac joint, which is a joint up here in the pelvis. And then there's problems of neuromuscular control. I can't tell you how often I'm seeing a knee pain patient, and I ask them if they have any numbness in their foot, and they say, yeah, my big toe is numb. Well, what that immediately tells me is that they've got a pinched nerve in their lumbar spine, which is affecting the muscles in their leg, which is leading to every time they step onto that leg, they're slamming far more stress and loading forces into the knee joint, causing it to fail. Step two is, pre-injection treatment. Before we do any injections, we need to treat conservatively. And what we're focusing on is preserving the range of motion so that the forces throughout the knee joint are distributed evenly. We're addressing any weakness in the dynamic stabilizers of the joint. And again, dynamic stabilizers of any joint are the muscles. That's why we send you to physical therapy and they instruct you in therapeutic exercise. We really focus on alignment. If your knee joint is out of line, maybe it has been for years, we need to focus on realigning. How do we do that? Well, we do that with orthotics in the shoe. We do that with braces at the knee level. And then if we find, looseness in the ligaments of your joint, which are the static stabilizers, we have to address that. How do we address that? Well, we address that with an injection technique called Prolotherapy. What's Prolotherapy? Prolotherapy is an injection defined as a growth factor stimulating injection. And what this is doing is it's addressing insufficiency in the connective tissue, your ligaments and in your tendons. Following an injury, any injury in the body, your local cells that are surrounding the injury, that are part of the injury, they begin to secrete growth factors, which initiate a repair process. But these growth factors are only elevated for a matter of days. And quite frankly, sometimes that's just not sufficient to heal the injury you sustained. And if the repair process is insufficient, that leads to chronic joint instability and chronic pain. So what we're doing with Prolotherapy, which is a technique that was developed about 80 years ago, is that we're attempting to raise the local level of growth factors to resume or initiate repair in a damaged area. Now, another way to think of this is that we're trying to give the body a second chance to repair itself, particularly at an injury site. And classically, what we're injecting into these tissues is 12.5% dextrose. Dextrose is a sugar, so this is basically sugar water. Sugar water is extremely pro-inflammatory. It's irritating. You inject it into any tissue and it will cause inflammation. And what this does is it causes cells that are injected in these soft tissues to begin to produce growth factors because that's their response to inflammation. Now, this is the good inflammation that we're causing. This is not chronic inflammation, and there's a distinct difference. And what Prolotherapy does, at bottom line, is you inject a ligament that's loose, floppy, torn, perhaps, and what you effect is a repair process that thickens the ligaments and it enlarges the footprint of that ligament when it attaches to bone. That's called the tendon-osseous junction. Orthobiologic injection. This is the next to final step in orthopedic regenerative joint treatment. What we discovered in Regenetics, regenerative medicine, is that if we use a patient's repair cells when we're doing Prolotherapy, instead of dextrose, sugar water, the Prolotherapy injection works a heck of a lot better. So what we're doing is we're injecting repair cells. We get them from your blood. These are small cells called platelets, or we get them out of your bone marrow where we're finding stem cells. And what we're doing is we're very precisely injecting them into damaged tissue. And this is the crux of the technique here. We inject them directly into worn cartilage. And more importantly, we inject them into the bone just beneath that cartilage. It's called the subchondral bone. It's right at that cartilage bone interface that you want to get these repair cells, because that is what will be most effective. We inject them precisely into torn muscles, torn tendons, and torn ligaments and cartilage. What we're stimulating is an inflammatory repair process. And quite often, this is something that we will repeat. If we go into a bad joint, we have to treat a lot of things, including the bone, the joint itself, ligaments around the joint. We all wish that we could do this just once and have it done for good. Quite often what we find is that we have to repeat the injection into the ligaments, because getting stability in a joint often takes repeat procedures. So let's come back to this seesaw balance of healthy joint. Healthy joint is, once again, balancing the forces that degrade the joint, the forces that repair the joint. And I want to use this to illustrate what it is we're doing. Let's say you walk into my office and you've got knee pain, and it's only developed a month ago. It's swelled a little bit. It's not so bad now. It's a little better, but you still have pain going up and down stairs, getting in and out of a car. We get an x-ray. We look at it. It doesn't look too bad. I do an exam. It doesn't look that unstable. I'm thinking, okay, I'm going to recommend an injection of your blood. We're going to simply draw your blood in office. We're going to centrifuge it. We're going to skim off the platelets, concentrate those, and we're going to do what's called a platelet-rich plasma injection. So we inject platelets. What are we doing when we inject platelets? What do we get? Well, we get a bunch of hormones and cytokines. These are hormones secreted by cells locally that work against breakdown forces in a degenerated joint. They immediately turn off the destruction that's occurring in the joint. And this is a destructive chemical microenvironment. What these platelets are doing are secreting these substances here that turn a destructive microchemical environment into a pro-growth supportive environment. Along with platelets, we'll get one very powerful growth hormone called platelet-derived growth factor, PDGF. And this stimulates the regrowth of vasculature, the regrowth of tendons and ligaments, and the regrowth of repair cartilage. Now let's assume a different scenario. Let's say you've been hobbling around on a painful joint for years. It's gotten to the point where you can't stand it anymore. It's inflamed all the time. You can't bend it. And it's really a bad joint. We get some imaging and I see that you've completely worn through some cartilage. You have involvement of the subchondral bone. And for this, we've got to up the ante. I've got to go get your bone marrow where I find stem cells so that we can do a stem cell injection. What do we get with stem cells when we do this? We get a ton of growth hormones. We get VEGF, FGF, IGF, CXCL. These are all powerful growth hormones. What we're in effect doing when we're injecting these orthobiologics is we're tilting the balance towards repair forces in the knee, the pro-growth forces, the anti-breakdown forces, and we're tilting this seesaw in the direction of repair and health. Let's go back to this standard treatment algorithm now. What have we done? The treatment algorithm that we've done has the same up until the MRI. At the MRI, we are going to take you out of the algorithm because I'm going to inject orthobiologics. We're going to do a regenerative orthobiologic injection. When we're done with that, we're going to send you back to physical therapy for more strengthening. And when this process is successful, what we have done is we have solved your pain issue, your instability issue, and the bottom line result is we have preserved your native joint or tissue. And we have taken you out of this algorithm, which is pushing you inexorably towards joint replacement. So how well does this work? Well, it works pretty well. Regenexx keeps data. We are the only people who do around these regenerative procedures that we do, and it's all published online at regenexx.com. And what we're finding is that we're able to help people with knee injuries avoid surgery. We're helping people with severe knee arthritis avoid a knee replacement. We're helping people with ACL tears avoid ACL reconstruction. Knee arthritis. Here's a study that Regenexx did in 2018. We compared bone marrow aspirate concentrate, that's stem cells, and platelet-rich plasma. We always combine them in the Regenexx world. Whenever we're doing stem cells, we're always also doing platelet-rich plasma. So this is a study where we took patients who came into the office with knee pain and we randomized them once they agreed to be in the study. We sent them to physical therapy, which is just exercise, or we immediately injected their knee after imaging and seeing what needed to be injected. And then we followed them for 2 years. The design of the study was that at 3 months, the exercise group, if they wanted, they could cross over and get an orthobiologic injection. Well, what we found was that at 3 months, there was a very significant statistical improvement in those we had injected with stem cells and platelets compared to the people we just sent to exercise. And the people we just sent to exercise felt the same way. They didn't get much better. So all of them crossed over, and all of them had stem cells and platelet injections. And what we found was that there was significant improvements in the people we had injected with stem cells and platelets at all time points from baseline. So we followed them for basically 2 years, and they were better 2 years out. Knee arthritis, avoiding knee replacements. Here's data. This is rather old now, but it does, it holds up. It does give this final result, which I really find eye-opening. We were following, at the time, 5,800 knees. 3,500 roughly of those had knee arthritis as a primary diagnosis, meaning they hadn't torn a ligament, they hadn't had a football injury 15 years before. They just had arthritis with getting older. We did stem cells in all of these knees, and then we followed them for 2 years. And what we found was that the people who were unhappy with the stem cell procedure and went on to TKA, which stands for total knee arthroplasty, or in other words, joint replacement, despite having stem cells in their knee, was only 12.7%. And this was 2 years after treatment. What that says is that 87 out of every 100 patients we treated with stem cells was happy enough 2 years out that they were avoiding joint replacement. Here's a study that just came out, 2021. This is out of France by an orthopedic surgeon named Ernegau, who's one of the gods in regenerative orthopedics. He took 140 patients, and these 140 patients had similar arthritis in each knee. He got them to agree to be in the study, and what he did was he injected one knee with bone marrow aspirate concentrate, or in other words, stem cells. The other knee he replaced. And then he followed them for 15 years. And this is what he found. After 15 years, whether the knee had been injected with bone marrow compared to the knee that had been replaced, the failure rate was the same. And when you say the failure rate is the same, you're saying that the success rate was the same. In the knees that were injected with bone marrow, 18% of them, 25 out of 140, went on to have a knee replacement. So we consider those failures. The average time when they decided to throw in the towel was 10 years after having a stem cell procedure. So even though they eventually failed, they got 10 years of avoiding a joint replacement. So the incidence of joint replacement surgery was 1.19% per year. Compared to the opposite knee that was replaced. Of those knees, 21 out of 140, statistically, the identical amount that from the bone marrow group that went on to joint replacement, 15% of the knees that had a joint replacement had to have a second joint replacement called a revision because the first surgery failed. The incidence of second joint surgeries was 1% a year, almost identical here. The conclusion is that this study showed without a doubt that orthobiologic injection using stem cells had a sufficient effect on pain to postpone or avoid total joint replacement for 15 years. This is eye-opening data. Here's another one by the same gentleman, Ernegau. He took 60 patients this time. They had the same, again, these are 60 patients with bilateral knee arthritis, judged to be about the same in both knees. He injected both knees with stem cells, but one knee, he just took the stem cells and threw them into the joint cavity. In other words, into the joint capsule, and that's all he did. The other one, he injected into the bone. This is called the interosseous, the IO group. He injected the bone beneath the cartilage that was completely worn away. Remember, we were talking earlier about the cartilage-bone interface. Very, very important. He followed these people for 15 years. What did he find? In the group where he just took stem cells and went into the joint capsule, what he found that over the course of 15 years, that 70% of these knees had to be replaced. The rate of total knee replacement was 5% a year. compared to the knees where he drilled into the subchondral bone beneath the cartilage that had been worn away. After 15 years, only 20% of these knees had to be replaced, for a joint replacement of 1% a year. And the conclusion here was, you got to go into the subchondral bone. Well, this study changed our protocols in Regenx, and for the past year now, we have been drilling into subchondral bone, which is improving our outcomes. Finally, ACL tear, avoiding ACL replacement. This is a procedure that we are very proud of. We call it PERC ACL. It stands for percutaneous ACL repair. And this is how it's done. This is a schematic view. We put the patient in what we call hook lying position. The operative knee is bent on the table like this. And we use a fluoroscope and we get these views. And this shows the ACL, the two bands of the ACL. And this is real-time fluoroscopic views of what it looks like. We're injecting dye into this ACL. Pilot study we did in 2015 just took 10 patients. We put in stem cells, 694 million cells, approximately 2.7 milliliters. We followed them for almost 4 months. We got a follow-up MRI, and all 10 had signs of a dramatic ACL ligament repair. So this was just a pilot study that we did. This is a fluoroscopic view showing the needle comes in from the front like this to inject the ACL, which is filling with dye that we're injecting here. There's quite an art to this. This is not easy to do, but it's just a needle. This is a before and after. This is a grayscale. This is a torn ACL. It's very dark here, as it should be. And then here it becomes very gray and exploded. This was read by the radiologist as a total tear of an ACL ligament. We injected it. We waited 4 months. We got a follow-up MRI, and this is what we see. The gray scale here is dramatically diminished. This is a much more healthy looking ligament. We did a much larger study in 2018, and we saw very significant improvements, approaching 80% at 8 months post-procedure. We did have failures, and I want to point these out. 5 out of 29 patients that we did went on to surgery. Of those 5, only one was a re-tear of the ACL. Compare that re-tear rate to the re-tear rates of surgically repaired ACLs, which approaches 30%. Here's another before and after, completely torn ACL, 5-6 months later, repaired ACL, all done with needles through the skin. So I want to conclude my discussion tonight just to sum up high points. Regenerative orthopedic joint treatment starts with getting a better diagnosis. It's very important that you understand why a knee has failed, because if you don't understand why a knee is failing, then you're not going to be able to address all the causes of that knee failure, and you won't be successful with what you do. That's very, very important. Regenerative knee treatment is more than just an injection. It very much relies on physical therapy to address the dynamic weakness of a joint, which are your muscles, physical therapy for improved range of motion, and then injection therapy, prolotherapy, to tighten up the ligaments, to improve stability. Very, very important. We use orthobiologic injection of stem cells and platelets to affect repair in damaged tissues in an arthritic knee. The bottom line is, when we're successful here, we're able to avoid surgery, we're able to avoid knee replacement, and we're able to preserve your native joint. We're able to take you out of the algorithm, which pushes you towards total joint replacement. That concludes my presentation this evening. I want to thank you very, very much once again for spending some time on a very rainy night on the East Coast to discover a little bit more about regenerative procedures. If anybody has any questions, I'll be happy to try and answer them. Looks like we have a question from Diane. Diane, you're muted. You have to unmute and you can ask your question.
Is it unmuted?
You're unmuted. Go ahead, Diane.
Okay. Yeah, I just wanted to know, is this a procedure that's done on a hip or a back as well?
We do these procedures on any joint in the body, and I do them because I'm a spine guy and trained. I do them on any joint in the cervical spine, which is the neck, or the lumbar spine, which is your lower back.
Mhm.
We do them on sacroiliac joints, literally any joint in the body.
And is this also covered by insurance?
No, it is not. That's a process that's coming. Regenx has approaching 10 million people who are getting insurance coverage for these procedures, but these are all patients who are employees of large corporations who self-insure their employees' health, and they're very interested in saving money on surgical, orthopedic surgical costs. So we come in and pitch them and tell them it's not going to cost you anything to add Regenx procedures to your covered services, and they do. And what they find is they save a lot of money on surgery, and CEOs are showing up at our annual conferences now and crowing about the amount of money they're saving. But in terms of large commercial insurers, no, this is not yet covered.
Okay, thank you.
Any other questions? All righty, I guess that'll do it. Thank you all once again. I really appreciate your time. And if you have any interest, please don't hesitate to call us. We'd love to take a look at your imaging studies or get them for you and tell you if we think that you're a good candidate for what we do. Thank you and have a good night.
Thank you.